Okay, we will start, Professor. Good afternoon, everybody. From the Robotic Surgery Academy, Dubai, we meet again with an important robotic surgery event, and with one of the experts in urology and robotic surgery, Professor Dr. Shaheen Al-Ani, the fellow of the American College of Surgeons and the fellow of the Royal Canadian College of Surgeons, urological surgeon, Detroit Medical Center. We are proud about his work, and as you've seen, and as the lectures that we presented for the robotic surgery programs in UAE and the Iraqi programs that will open soon in Iraq, these are very important lectures in many specialties. We have gave robotic GIT surgery, robotic virtual reality, 3D surgery, and today we are giving the robotic urology. Any questions of the audience, we'll be very happy to answer. You can write it in the chat, and of course, Professor Shaheen will answer you, and we are proud. One of the success rate of the robotic surgery is the accuracy and precision of the surgery, and you can see what will the professor present today is the organ sparing in urology, oncology, and robotic oncology surgery. And believe me, without using a robot and the abilities of the robotic surgery, you will see no one can do what you will see and what is done. Our aim is the quality and the precision and the success rate of surgery, and this is why you can see the revolution. Till now, only 5% of the total 100 million surgery per year is done robotically. And believe me, and you will remember what I'm saying, within the coming 5 years, about 40% of the 100 million surgery will be done by robotics. So this is why what we are doing, and the robotic program that you are seeing is developing in many countries in the Arab region and of course in the international regions. So now the microphone with you, Professor Shaheen, to start your lecture. Yes. So now you are an admin and you can join.
Mohammed, thank you so much for the introduction. This was a very good collaboration, and I think we're going to have a lot of good things to do together. So I totally 100% agree with you that, I agree with you 100% that in the next few years, you're going to see that robotic surgery is going to become the standard of care in the management of any kind of surgical problem because of the better vision, better tissue handling, and because of the better outcomes, less pain, less bleeding. Patients are getting out of the hospitals very quickly. So this is becoming the standard of care. So like when we do in my practice and at Detroit Medical Center, I would say maybe 1 or 2 cases are done with open surgery a month. The rest is all robotics, and this is what we are doing in our practice. Okay. So what I wanted to do, let's see if I can share my screen with you. Let's see this. So Mohammed, can you see my screen? And open.
Yes.
Share screen.
He's in. Just check. Yes, we can see now.
You can see now. Okay.
Yes.
Okay. So what I'm going to be talking about is organ preserving surgery in urology. And we're going to be talking about for 15 minutes about the different organs we can preserve and why can we preserve them. And then I'll show you a video. This is a video of treating prostate cancer with preserving most of the prostate, so that the issues of erectile dysfunction and the issues of urinary incontinence are no longer a problem when we treat prostate cancer. So Dr. Mohammed Al-Ansari gave a fantastic introduction. I did my residency. I did my first residency or part of it at the University of Baghdad, and I have fond memories of the people there at the University of Baghdad. Then came to the United States, did a residency at the University of Minnesota, training in urologic oncology at Memorial Sloan. And then I've been a member of the Society of Urologic Oncology and Genitourinary Reconstructive Society since then. I served as the Director of Urologic Oncology at Southern Illinois University, and then Director of Clinical Trials on Bladder Cancer Program at Henry Ford Healthcare System, and now I'm with Detroit Medical Center. So When we talk about organ preservation in urologic oncology, we are talking about using, there are options. So for prostate cancer, there is focal therapy, precision prostatectomy, and what we call urethra-sparing prostatectomy. For bladder cancer, we do intravesical therapy because we want to preserve the organ, but surgically and robotically, we can do what's called a partial cystectomy. And then for kidney cancer, obviously, it's partial nephrectomy. So why do we do organ preservation? Because this has been used in other organs. So we in urology, we did not invent this. This was started by breast surgeons. This has been started by head and neck surgeons, colorectal surgeons, because we are trying to avoid any kind of functional and cosmetic side effects. Okay. 2, cancer maybe is, or sometimes, most of the time, I would say about 50% of the time, is a systemic disease. So what we are trying to do by minimizing the functional and the cosmetic side effects of our surgical treatment, we are trying to be part of this multidisciplinary team where the patient is receiving systemic therapy and we treat the local disease without altering the quality of life of this patient. We are able to do organ preservation now because we have better imaging. We can do 3D modeling of whatever organ we are approaching with robotic surgery. And because robotic surgery is now available, because what I'm going to show you in that video, this was not possible before robotic surgery. It's very hard to do these organ preservation procedures with the old method. Like if you're working on a prostate, the people who did and are doing open prostatectomy know it's very hard to see inside the pelvis. It's very hard to dissect the prostate from the surrounding organs and so on and so forth. And then finally, now we have molecular markers. So with the molecular markers, you can tell whether the change in the prostate or the change inside the bladder, if this is a field change or this is a change localized to one area of the organ, and then it will be that area that you can be removed. And then we have better adjuvant therapies. So now we have immunotherapy, radiation therapy is getting much better. So you can treat the specific area inside the prostate, the bladder, or the kidney, and then you can use those adjuvant therapies to prevent local and systemic recurrence of the disease or of the cancer. Okay, let's see. There we go. So big and very, very well-known example. This is the progress of organ preservation in breast cancer. So we went from the Halstedian, where everything is taken out, including the pectoralis major and minor, to lumpectomy, and the survival is still the same. So it's better understanding of the disease, better quality of life for the patient, and I think this is the way where surgery is going to progress in the future. When we talk about prostate cancer, so this is from the research that was done on focal therapy in prostate cancer. 80% of prostate cancer is represented by what we call an index lesion. This is the aggressive type of prostate cancer. This is the cancer that spreads. It does not mean that there is not going to be cancer in the rest of the prostate, but when they looked at the lymph node metastasis and then when they looked at the clonality of the metastasis for prostate cancer, 80% of the disease is just coming from one area. So it makes sense to treat that one area and preserve the urinary incontinence and the sexual function. 80% of prostate cancer develops in the peripheral zone of the prostate. So central and transitional zone are not affected, so we can spare them, okay? The natural history of prostate cancer is that of slow progression. Actually, I was reading this paper this morning, and what this paper is showing is that in patients who have Gleason 7 disease, the chances of dying from prostate cancer is less than 25% over 10 years. So it's actually just the very aggressive type of prostate cancer, the Gleason 8, the T4s, the lymph node metastasis or the bony metastasis. Those are the cancers that are actually would actually have a high level of mortality within 10 years. And that's why we can treat the disease that is less aggressive with organ preservation and make sure that this disease doesn't progress and the quality of life is good. And then finally, focal therapy is well established with specific criteria for patient selection and response to treatment. So when we say organ preservation for prostate cancer, people have done a lot of work on focal therapy. So we know what the outcome points that are going to predict that this cancer is not going to come back. There is a consensus statement, and we know what the PSA results that we should be looking for. When would you use organ preservation in prostate cancer? This is if you have a patient who's interested in preservation of sexual and or urinary function. This is very, very important. At this point in time, I'm just using this for patients with favorable type of prostate cancer, Gleason 3+3 or 3+4. Preferably, you would have an MRI that shows an index lesion, so that would be the area that you would remove. You have to have appropriate counseling. The patient should understand that what he's going to get for a surgical procedure, so that he doesn't go to a different provider and they say, well, they just removed part of your prostate. So if he does not understand that very well, I would not do organ preservation on him. We do repeat biopsy in all of those patients because the diagnosis of prostate cancer is dependent on sextant biopsies. So we do a transperineal mapping biopsy so that we make sure that whatever area is left inside the patient, that area does not contain aggressive cancer. Some patients we use field cancerizations markers, not for all patients, and we also do 3D modeling so that we can actually explain to the patient where his cancer is and what area of the prostate we are going to be removing. Now, I'm just going to move quickly. I'm going to give you an idea about what's going on with bladder cancer and with kidney cancer, and then I'm going to show you the video for the actual procedure for organ preservation for prostate cancer. So for bladder cancer, we have data from radiation therapy that shows that the recurrence happens most of the time in the same location. So if you have a muscle invasive type of bladder cancer, when the recurrence happens, it happens in the same location, doesn't happen in other parts of the bladder. If the patient has muscle invasive bladder cancer and there is recurrence with superficial type of bladder cancer in the rest of the bladder, that type of bladder cancer actually responds very well to intravesical therapy if you have a compliant patient. So if you have a compliant patient, you can treat the more aggressive disease with removal, and then the superficial type of bladder cancer that happens in the rest of the bladder, that part can be treated with intravesical therapy. Positive surgical margin is not a death sentence. So there is a difference in the definition of positive surgical margin from the time when we did not operate on the patient until his disease is T4, and this disease is systemic. This is very different from positive surgical margin that we talk about now, where it is the type of positive surgical margin that is microscopic and then can be treated with the adjuvant therapies, whether it's the radiation therapy and again, the hormonal. Let's see. So, give me 1 second here. Let me mute this so that we don't get the feedback. Okay, so when do we choose the patient partial cystectomy? This is when you have a patient with muscle invasive disease of the appropriate size. So 50% of the bladder or more should be kept inside so that you have a good capacity of bladder that store urine and excrete urine with no overflowing content. I do random bladder biopsy all around the tumor to make sure that the areas are negative. Location of the tumor. So this is where robotic surgery is good. If you look at the older definition, partial cystectomy says it is specifically done for bladder cancer that is at the dome of the bladder. And that is only because that is the area that you do an open incision. But now that you have any part of the bladder, even in the area of the trigone. So the location of the tumor doesn't matter. You can do a partial cystectomy in any area inside the bladder. The appropriate so that you're not surprised when you go into a partial cystectomy. I think neoadjuvant chemotherapy is a plus because obviously, let me see. Dr. Lansari, I may not be hearing you. 1 second. Dr. Lansari, did you say something? Okay. And then we have to appropriately counsel the patient.
Yes, can you mute one participant from your side? Try to mute him. Nawaf, his name is Nawaf. You are the admin.
Nawaf. Mute Nawaf. Done.
Muted. Thank you. Yes.
Good.
Thank you.
And let's go back. And so I was going to say that neoadjuvant chemotherapy is a plus. And that appropriate counseling. So what happens is that you, again, need to tell the patient what type of surgery they are going to have and let them know that they might receive adjuvant radiation therapy. So 1 second, let me just admit those two guys. Done. And let those guys know that they're going to receive a partial cystectomy for the treatment of their disease. Okay, so let's go back to this. Kidney cancer, partial nephrectomy is well established. Very good. To the point of Dr. Al-Ansari, even in the United States, only 10% of tumors that are appropriate for partial nephrectomy are treated with this approach. But the market, this is Dr. Al-Ansari, this team is on the cutting edge for surgical treatment. So when Dr. Al-Ansari is presenting robotic surgery, he's on the cutting edge. Even in the United States, 90% of the kidney tumors, for example, are being treated with open approach. The entire kidney is removed. Okay, so this is something very new. So that's why with robotic surgery, it's possible to do the partial nephrectomy without having the morbidity that is associated with big incision. You do it through small incisions, and then you're able to remove the tumor. There are two techniques. Okay, so for kidney cancer, you treat with a partial nephrectomy, you maintain the kidney. If there is any issue, you can come back and you do a radical nephrectomy. And now, if you have a small renal mass and you did a partial nephrectomy and there are any issues, there is now the stereotactic radiation therapy that can treat that specific area and decrease the chances of recurrence without using radiation therapy to the entire kidney. And again, appropriate counseling. The patient has to understand what type of treatment he is getting. And I see Dr. Khalid Al-Safi is joining us now, so big honor. Okay. So this is what I have as far as the slides. Any questions before I show you the video?
Professor Shaheen, can you just mute all the participants, please? Some noise there is coming from your side.
Yeah, so what did you say, Dr. Al-Ansari? I didn't hear that.
Try to mute some audience.
Okay.
Can you just check, please? Your list. Mute them, except me. Yeah.
So you are on. Yeah. Okay, so I'm going to mute.
Yes.
Mute.
Yes. Yes.
Done. And Dr. Haider is asking a question.
Yes, can you hear us? Yeah. Can you hear me?
Yeah, absolutely.
Yeah, hi. My name is Haider. Actually, I'm a resident doctor. I'm working in Aalborg University Hospital in Denmark. It's, of course, it's a side question. You say like about the negative, biopsy from bladder, but now we here in Denmark, in our hospital, we don't use any more negative, or we don't use the random biopsy.
Yes.
We use the NBI and Hexvix. So I don't know how it's in USA right now.
Yes. Yes. Very good point. Very good point. So I'll tell you the reason I use negative biopsies is more for a medical legal reason than anything else. Here in the United States, the environment is very litigious. So when we do these procedures, beside counseling the patient and letting them know now that this is like, look, this is a field change, it could happen in the rest of the bladder. I take these random bladder biopsies more as a protection because, again, you can remove the muscle invasive disease. If there is a recurrence with high-grade superficial disease, then that high-grade superficial disease can be treated with intravesical therapy, successful 75% of the time. So this is more of a medical legal approach than anything else for us here in the United States. Any other questions? Okay, Dr. Al-Ansari, do you think?
Hello, Can you hear me?
Yeah, I can hear you.
Yes, Professor. I prefer the questions in the end of the lecture. Let us see the videos, and after that, of course, we will answer any questions. Yes, Professor.
Okay.
Okay, so let me show you. So here's the video. I'm going to share with you a video for. This is a what we call a precision prostatectomy. 1 second. Let me, before I do that, I think there is somebody else. There is still somebody unmuted. So 1 second. There we go. Okay. And Dr. Ansari, can you hear me okay?
Yes, dear, I can hear you clearly.
Okay,
yes,
good,
yes.
because I wanted you to comment on the video with your expertise while we go through this.
Yes.
Because I watched your previous lectures, and I like the way you moderate those videos. Okay, doke.
Yes,
there we go. So
yes, Professor, be ready for telementoring. Actually, it is the technology that you will use to guide the programs. It is a nice technology of telesurgery between Dubai and Florida, Dubai and Detroit, and Dubai and Tokyo, and of course it will be Tokyo and Baghdad, Detroit and Baghdad, and so. So it's a nice exchange. Believe me, telesurgery now it's approved by Japan, by Singapore, by South Korea, and by Dubai, UAE, and by part of the states. The United States of America, part of the states approved it, and of course, I'm sure within the coming 2 years, it will be an international approval for all after what they found. So we are with you now with your practical work, and let us see.
Okay. So what you're going to see now is, so this patient, so remember, this is a robotic assisted laparoscopic radical prostatectomy. The left of the screen is the left of the patient, the right of the screen is the right of the patient, okay, the right side of the patient. And the idea again is, let me admit, and the idea is basically what we are trying to do is that we are trying to spare the capsule of the prostate and not touch the neurovascular bundle on the left side of the prostate. And we're also trying to spare more of the sphincter. So let's see, okay. And what we are trying to do also is that we are trying to spare more of the sphincter so that the risk of urinary incontinence is less. Okay, so what I'm showing you at this point in time, I removed some of the beginning of the procedure just to take you to the meat of the organ sparing. So the bladder has been separated from the prostate. Posterior dissection has been done, and this is an SI robot that we're using. Okay, so this is the vas and the seminal vesicle are held up. Obviously, the right side is the side where we found the cancer, and we did transperineal biopsies. Those transperineal biopsies did not show cancer on the patient's left side. Okay, I'm going to admit. Okay, see where we are marking. The video is about 10 minutes. So see where we are going above the vas and the seminal vesicle on that patient's left side. We get into this plane. Okay, and we are going around. We are trying to leave or spare as much tissue on the left side as possible. And the only parts that I took out of this video are the parts where we are actually switching the camera. So nothing else is.
Professor Shaheen, please, we cannot see the video on the share screen. Can you see your video? The problem that we cannot see.
So I see, let me see. You cannot see the video, you said?
No, we cannot see on the share screen the video.
Okay, 1 second. Your screen sharing. about now? Can you see something?
If you can, yes, now we are seeing, yes, thank you.
You see it. So do you want me to take you back to, 1 second.
Yes, please take it back 2 minutes.
To the beginning of the video?
Yes, thank you.
Okay. Dr. Ansari, do you see the screen?
I can see now the screen, yes.
Okay, so I'm going to start the video again.
Yes, thank you.
You heard my discussion about doing the transperineal biopsies and making sure that the left side doesn't have cancer. Okay. So this is the bladder separated from the prostate. The posterior dissection has been done. The vas and the seminal vesicle. Okay. Vas and seminal vesicles are separated, lifted up. We're trying to spare what we can of the left neurovascular bundle. Okay. This is marking it. Okay, let me see. I just need to mute some of the participants.
Yeah, of course, yeah.
Mute.
So you are using on your right side the hook and on your left side the grasper. What you prefer to use in such way?
Yeah, this is the Maryland.
Yes.
Because the Maryland is nice for the dissection.
It has amazing, yes, in cauterization and dissecting. We can.
Correct.
Yes.
So that's creating the plane. I'll show you creating the plane between the, see how I'm keep on links with surgical procedures. And this is again, MRI, transperineal biopsies to all left on the left side of the prostate that is staying inside the patient. Okay. And this is also born of the practice that we have here in the US, where you don't want to make like appropriate counseling, biopsies, imaging, because you don't want to get into a situation where it's a litigious situation and the patient is going to sue you because you left behind it. Like, it has to understand very clearly what we are doing here. Okay. So this is the part where you're going to see us taking the biopsies. This is more biopsies.
Amazing, yes. So now you are taking biopsies just to check that you are on the safe side, yes.
Correct, frozen sections.
Yes.
Because if the frozen section comes back positive, then positive for what we call an aggressive type of prostate cancer, depending on the counseling of the patient, or significant type of prostate cancer, then we'll take the rest of the prostate out. And obviously, this is a 14-gauge cannula that's coming out in through the skin. And this is the same biopsy gun that we use when we do an ultrasound-guided transrectal or transperineal prostate biopsy. This is all new, so we don't have the logistics to make this happen better, but I wanted not to edit the video so that you can exactly see. I don't want to make it look very smooth.
So you are here preserving the urethra also. The urethra, of course, is preserved.
So you'll see that
amazing
part too.
Yes, and the neurovascular bundle is preserved. And believe me, one of the drawbacks of prostatectomy is the neurovascular injury that can occur. And of course, now this is an amazing progress in surgery.
Correct.
So let's say, Professor, you are removing 25% of the prostate, let's say the lateral loop or the anterolateral.
No, so I would say we left maybe 25% of the prostate, because I'll show you. So once we are done with this, you'll see what happens on the other side, on the right side.
Yeah.
This is the part where I'd love to operate in India because people are slimmer So you don't have this much difficulty trying to put a needle through. Okay. See, we're bringing those biopsies. Take a biopsy. Okay. So we biopsy multiple areas. You see, Dr. Muhammad, I'm going to unmute you. Dr. Ansari, do you hear me?
Yes, I can hear you. Yeah.
Okay. So we're done with the biopsies. Okay.
Yeah.
And the frozen sections. This is the other side where we are going to do what we call standard neurovascular bundle sparing. Nope. This is the standard neurovascular bundle sparing. We're sparing the bundle on that side, just like you do with any regular radical prostatectomies.
Professor, how many time you need your video more? The time you need more for your video?
How much time I need for my video? Maybe like 3-4 minutes left.
Yeah.
I can forward it just a touch more.
Yes.
Second, because here this is people seen that. I'm going to take you to the part where we do the urethra sparing.
Because maybe we are running out of time, but we have other link, emergency link to give. Yes.
And
yes.
Okay, that's separating more on that left side, below the neurovascular bundle. And let me take you. You asked that question. I'm going to show you the high release. Not there. Okay. So this is what's called high release. We just go under the neurovascular bundle and see how much we spare out of this urethra, so that we spare more of the continence mechanism, so that this patient is continent and has a high chance of not leaking urine. And it's going to end. You see how the urethra is spared of this section?
Yes, Professor, thank you. Of course, I rather that now you will answer the questions. Thank you. Believe me, your experience and your vision was very clear of what you are doing. So let us go now to the question. If there is any question, I will open the chat and see, and I hope you will see with me. Okay, if you have.
Yeah.
Do you believe in diathermy concepts for dissecting the seminal vesicles and around? How do you manage the prostatic specific antigen from residual benign tissue in the post?
Okay.
One of from Professor Khalid Safi. Yes.
So as far as the diathermy goes around the dissection, this is something that I learned from Manny Menon, because I worked with him at Henry Ford healthcare system, and we had a lot of discussion about that. Obviously, he published his outcomes, and it's proven from his series that using the diathermy in that location does not affect the outcome of sexual function that much, compared to the series where people use clips or just use cold dissection. So I just followed his method. I used to use the scissors. I used to use the scissors before when I do the dissection, but since I worked with Menon and saw what he did and saw his results, I'm going with the hook. What was the other question, Dr. Ansari?
This is one of the question only. This was one question, and believe me, if there is any question, please don't hesitate to write. The professor is ready to answer, and Professor Shaheen, be ready with us in telementoring robotic, the first robotic prostatectomy in Baghdad, Iraq. We'll be very happy to publish this in the coming month. I hope you will be with us in a telementoring process in robotic prostatectomy.
Inshallah.
Inshallah. So let us see if we have any question. Yes, one question from me. The time that you take in organ preservation, is it better? Of course, it is less than the total prostatectomy. The time, will it reach 50% less the time? And of course, the recovery is more. Yes.
Yeah, so the recovery is better. And I would say the time, so if you do a radical prostatectomy, it probably takes you about 50 to 60 minutes. This procedure, it's 10 minutes video, but it actually takes 30 minutes to do this.
Amazing. Yeah. So for all audience, this is what we are speaking about, the revolution. Believe me, these techniques will be popular. It will need a lot of data to be published and strengthened. But of course, like what we have seen in revision bariatric surgery and oncology surgery, and now in liver transplant and robotic liver transplant, the data is going with more and more with robotics. So at the end of this webinar, thank you, Professor Shaheen. Thank you for all audience. And if you have any question, don't hesitate to write for us, and be ready for a nice coming lecture on the 8th of October, the robotic cardiac surgery with one of professors of Philadelphia. So thank you very much all. We are happy that you are part of our journey in the robotic programs that are occurring in the Middle East, and we are proud of you all.
Okay. Thank you so much, Dr. Al-Ansari.
Yes. Yes. Thank you very much. And in this, we will end the webinar, and best regards for all. Thank you.
Thank you very much.